As we're headlining this afternoon, en route with touchdown imminent, the International Relations and Cooperation Ministry confirming that the first shipment of COVID-19 vaccines will arrive later this afternoon within the next 2 hours. The shipment contains 1 million doses of the Oxford University AstraZeneca vaccine from the Serum Institute of India. With me now on Monday lunchtime is Professor Adrian Hill, Director of the Jenner Institute at Oxford University, where the AstraZeneca vaccine was created and first tested in trials. Professor Hill, good afternoon to you and thank you very much for joining us. First of all, maybe let me start with a personal note if we can. This is your co-discovery. How do you feel when you bear witness to something as important as this travelling globally? As I mentioned in our headlines, right now South Africans are anxiously awaiting the arrival of this aeroplane.
Well, of course, this is a privilege to be able to contribute to what is an enormous global public health emergency. It's interesting from an African perspective that the vaccine technology that underpins this particular vaccine is one that was really developed for Africa for a different disease, that was for malaria, which I've been working on for over 20 years. So it's fantastic to see this vaccine being supplied from the Serum Institute of India, this particular batch, to South Africa, where, of course, the need is very, very urgent to combat COVID.
Professor, I wonder if we can talk a little bit about these percentages. We read that this particular vaccine has proved to be 90% effective in one trial. Another says it's only 62% effective in another. Could you make some sense of those percentages and what we need to be looking out for?
Yeah, it's very simple, really. Unlike some vaccine programs, we took the opportunity in our phase 3 trial to look at different immunization regimens. And the short summary of what we found is that if you give a large interval of, say, 12 weeks between the first and second dose, you're achieving vaccine efficacies of just over 50%, over 80%, in 90%, as you mentioned there, in one of the subgroups, but very high efficacy. If you give the vaccine at 4 weeks, you're getting lower efficacy of the order of 60 to 70%. So what we learned from those trials is that if you can, you should delay the second dose, and that's now the policy in many countries, including in the UK, and the European recommendation last week was to do the same. So it's not surprising, it's not confusing, it's pretty straightforward that if you can do a 3-week interval between priming and boosting, that is preferred.
Professor, there is some concern in this country about its efficacy against the virus strain or the variant that was discovered in South Africa. Do we need to worry?
We need to look at it, and that's exactly what's going on in labs around the world, including here in Oxford. There are two pieces of good news. The first is that all of these effects of different variants are going to be quantitative. There won't be a complete knockout of the efficacy of the vaccine. And the vaccines, as we've just said, are already pretty effective, 80% plus to some even 90% against the original variant. And the other bit of good news just in the last week is when another vaccine from the Novavax company was tested in South Africa, yes, there was a reduction against the variant, the South African variant, but the efficacy was still 60%. Now, those of us who've been in this field intensively for the last year are well aware that what everybody wanted, say, 6 months ago, was a vaccine that was 50% effective. So even against the variant where you don't get the very high efficacy, you still get 60% efficacy against mild to moderate COVID. And remember, if you look at severe COVID or risk of hospitalization or risk of death, the efficacy is always higher. It's close to 100%. For essentially all of the vaccines that have been looked at so far. So it may be that eventually we might need to make a South African variant-specific vaccine, but for the moment, the vaccine arriving today is going to be very useful against the original strain and against the South African variant, is my personal view.
You would have seen reports, Professor, out of France at the weekend that says that this particular vaccine is not effective for people over 65.
Yes, those reports were incorrect. I think everybody's clear about that now. And most importantly and most reassuringly, regulators who are experts in this field for all of the 27 member states of the European Union voted in favor of use of this vaccine, not for young people, but for all ages above 18 years. So in the UK and in 27 other European countries, this vaccine is approved from that age onwards, because the data that we have from clinical trials are that the immunogenicity is just as good in older adults over 70 as it is in very young adults.
Well,
I think people can be reassured.
As one of those older adults, Professor, you certainly have set my mind at rest. I want to ask you to give us a view on the so-called anti-vaxxers, the people that are hesitant about taking the vaccine. We ran a survey in South Africa about a fortnight ago. Alarmingly, 47% of respondents were saying that they had concerns, that they didn't want to take the vaccine. How do you respond to surveys like that?
Yeah, well, the first thing to do is to understand what you're actually measuring there. There are two very different sets of people. A very small number of people are just against all vaccines on principle for reasons that they understand but are hard for other people to understand. A much larger group of people are sensible, have concerns that they need addressed, and that's really a messaging issue. We have to get out there the information that we now have on COVID vaccine. So take our Oxford AstraZeneca vaccine, for example. That's now being given to millions of people, not in a research trial, not in a research environment, but being deployed in the UK and other countries. It is licensed in, I think the number today is 43 countries around the world, reviewed by experts in the field who are confident that this should be deployed in their country. And that number is going to increase, of course, to many more countries in the coming weeks. So a lot of experts have looked very carefully at this. They do this for a living. They've reviewed other vaccines. The track record of vaccines overall is really excellent, much better than, say, the safety of drugs. So I think people should be reassured. That doesn't mean there isn't work to be done by public health authorities to get that message and understanding out. And that's very much a work in progress in many countries. But one last thing I would mention, when we had those studies done in the UK a few months back, when the vaccine was said to be coming, and it was, the figures were something like 60 to 75% of people saying they would have the vaccine. Now that it's being rolled out and people are queuing up in some places down the street to get vaccinated, the latest surveys are saying 90%. So we'd like to think that people are reassured by the increasing amount of safety data on all of these vaccines, and the fact that people they know and care for have had the vaccine and are very keen to have it. So let's see how that goes.
Professor Hill, you talk about all these vaccines, which leads me on to another question. There are other vaccines that are also being rolled out. How do people make a choice if they have to make a choice? Should one be selective?
Usually one doesn't have to make a choice. At the moment, there's a supply constraint on all of these vaccines. There are probably 5 billion people around the world who could benefit from being vaccinated. With 2 doses, that's 10 billion doses needed this year. That's a very big ask for the manufacturers, and they're gearing up as fast as they can. So it's an issue that most people are not faced with, deciding which vaccine. If you're offered one, my strong advice would be to take any of the licensed vaccines. But, you know, they are similar in that they're generating an immune response against the same coronavirus antigen, the so-called spike protein, and they're all performing pretty well if they have been licensed, and in fact better than we had hoped 6 months ago when we were aiming for more than 50%. The particular advantages of the vaccine that arriving today in South Africa, and this is one that we worked hard to be able to provide, is that no freezing is required. The RNA vaccines need a freezer, sometimes a deep freeze. They are stable in the fridge for considerable periods, probably 6-12 months. They are easy to deploy, no complex devices needed. and a very extensive safety record in trials of over 60,000 people, and then millions of people already vaccinated in programs of vaccination.
Professor, I do appreciate the insight and your time. Professor Adrian Hill, Director of the Jenner Institute at Oxford University, where the AstraZeneca vaccine was created and then first tested in trials. This is